This is the case scenario. 24 years old circus trapeze artist. He fell from there. Mostly spinal cord injuries are classified into high spinal cord injuries and low spinal cord injuries. Depending upon, most of the time in the motor vehicle accidents and other things, you get a cervical spine injury. And the management of that is totally different. You have to mainly manage by a proper airway management, and immobilization of the cervical spine is very important to prevent or aggravate the spinal cord injury. Whereas low spinal injuries like lumbar level, usually they don't cause that much of a problem. But in both cases, which particular clinical examination will tell you the severity of spinal cord damage? What is the test that the neurosurgeons will do to find out whether it is a complete damage or incomplete damage, both in high spinal cord and low spinal cord vertebral injuries? Which reflex you have to check for? Anal reflex. Okay, if anal reflex, that is sacral reflexes are preserved, that is a milder type of injury. If anal reflexes are lost, that is a very severe type of injury. Okay, so that is what we keep in mind. So here, as she rightly said, it may be transient or permanent loss after an injury of all the structures, that is motor, sensory and autonomic, all will be lost in these cases. And in patients with spinal trauma, spinal immobilization with rigid spinal board, if it is spinal cord at the cervical level, vertebral injury, you have to do the cervical immobilization. For the lower vertebrae, you have to do what is called the rigid spinal board maintain alignment. Because if this case scenario is given in the exam, they may ask you about management of spinal cord injuries, and that is the reason why I'm just telling you acute management is immobilization and hemodynamic imbalance, and also look for any life-threatening or limb-threatening associated injuries and first attend to them rather than trying to attend to the spinal cord injury. And acute injuries present with spinal shock, especially the cervical spine injuries, they produce what is called the spinal shock, which is an acute state of diminished spinal function, characterized by loss of all sensory motor function caudal to the site of injury. And here, one question they may ask is, if the patient has a cervical spine injury and he has a BP of 80/40, how will you manage that? He has got C4, C5, C6 vertebral fracture, and he has got no power in the upper and lower limbs. He is quadriplegic, and he has been brought to the emergency room after a motor vehicle collision, and his BP is only 80/50. How will you manage that? After confirming that he is quadriplegic, how do you correct or how do you treat the hypotension in a cervical spine injury patient? Will you give rush fluids like you do in any trauma patient, or is it a different type of treatment?
Adrenaline infusion can be started.
You have to go for vasopressors, okay? Not to give fluids in this. That is the major difference between a normal hypovolemic trauma patient where they have lost a lot of blood or fluids, between a patient in spinal shock with a high spinal vertebral injury. Okay, so don't give fluids because they will not respond to the fluid. They will only land up with fluid overloading. Rather, you have to go for vasopressors like noradrenaline or dopamine, and try to constrict the by direct action. You have to constrict the vessels to bring up the BP and not rely on fluids. That is the main difference between the spinal shock and other types of hypovolemic shocks. And as you rightly said, it develops in two stages, primary and secondary. And primary is because of the mechanical trauma caused by either compression of the spinal cord, hemorrhage, traction, or penetrating trauma. The secondary is follows within minutes of initial injury, and this is the injury which is secondary injury, which is going to decide the extent later on, because it involves the mechanisms of ischemia, hypoxia, inflammation, excitotoxicity, lipid peroxidation, and apoptosis of neurons, and it may reach maximum. So spinal cord injury, I mean neurological injury, whenever you assess on the day 1, it may not be the same on day 2, day 3, day 4, up to 6 days. It may gradually increase or become static at that particular level, depending upon all these mechanisms. So it is always important to review the patient every day to find out the extent. It may not be the same as on the day of injury. So during the secondary survey, patient's neurological status should be documented for further management. And there is a classification by American Spinal Injury Association, Asia score, which classifies into 5 grades, A, B, C, D, and E, okay, which involves the 2 things: muscle groups of 10 muscles strength is assessed, and also sensory. For sensory, you do the pinprick discrimination at 28 specific points in the sensory locations. So when they you grade it as A according to Asia grade, it is a complete loss of motor and sensory function, very severe damage. And when it is E, it means it is a full intact motor and sensory function with a transient loss of some functions of the neurological system. And the grade B, C, D are in between the A and C, A and E, where there's a progressive less severe involvement of motor and sensory pathways. And it is complicated by systemic hypotension and reduced spinal cord perfusion. Just like your cerebral perfusion pressure, you have a spinal cord perfusion pressure. Can you tell me how you calculate the spinal cord perfusion pressure? How do you calculate the cerebral perfusion pressure?
Mean pressure.
Mean arterial pressure minus intracranial pressure is the cerebral perfusion pressure. Similarly, for spinal cord perfusion pressure, it is the mean arterial pressure minus the CSF pressure in the spinal system. So that is how you calculate the spinal cord perfusion pressure. And the perfusion is also auto-regulated over a wide range, just like the cerebral blood flow. And the main goals in the management of spinal cord injuries is you must maintain a mean arterial pressure of 85 to 90 and avoid systolic blood pressure going to less than 90 millimeters for at least 5 to 7 days. Don't be happy that you have resuscitated acute injury state and be relaxed. Up to 5 to 7 days, they can again go for reduced spinal cord perfusion, which will aggravate from the primary injury to the secondary injury. It will worsen the condition. So these patients have to be carefully managed for 5 to 7 days. And phenylephrine can also be used to counteract the peripheral vasodilatation associated with lower thoracic and lumbar cord injuries. Now coming to the simple management and challenges in this particular cases are risk of hyperkalemia with use of dexamethasone if the paralysis has been there for a long time. So patients who have been bedridden with paraplegia for a long time, as Soundarya said, they may develop extrajunctional acetylcholine receptors, which may suddenly, just like your burns with major trauma or crush injuries, all these patients have this tendency of developing extrajunctional acetylcholine receptors, which will get stimulated, and hyperkalemia will result if you use dexamethasone. The second risk is sympathetic hyperreflexia. These are the 2 challenges in these cases. And pre-op assessment with the routine examination to assess the severity of injury and subsequent recovery, with specific examination for sensory loss and recovery at the operative site. Routine blood investigations and include serum potassium levels also. In case you are planning to use dexamethasone for a difficult airway for GA, always measure the serum potassium. Routine rule out UTI, urinary tract infection, if the patient is on long-term catheterization. Discuss position for surgery with the surgeon, as it may be lateral or prone posture. and also discuss the possible duration of surgery with surgeon to decide the anesthesia. Avoid antacid and prokinetics to prevent gastric reflux. Advise antacid and prokinetic. Now coming to the plan of anesthesia, it depends on two factors. Presence of any sensory recovery at the incision site, which may require infiltration with local anesthetic without adrenaline if the patient has features of dysreflexia, or with adrenaline if there is no dysreflexia. Other thing is, when presence of symptoms of dysreflexia is another important consideration to decide the anesthesia. So the choices are sedation with or without analgesics. In total loss sensation at the operative site, you can use just midazolam or propofol infusion to make the patient slightly sedated. If the patient has some mild altered sensation and the surgeon is planning to infiltrate with local anesthetic, you can also give small doses of fentanyl for aiding the local anesthetic infiltration. And if the patient has dysreflexia, the choices are, you can go for a central neuraxial blockade. Spinal is not contraindicated in a paraplegic patient. Please be aware of that. And GA, if the patient refuses spinal, or if there is a site injection infection very close to the site of spinal, then you have to go for GA. And the GA, whatever she described, avoid potassium. If you are, avoid succinylcholine if potassium levels are high. And other routine management like induction with propofol, intubation with non-depot dressing muscle relaxant, maintaining with the air isoflurane and oxygen, and incremental control ventilation to provide good ventilation. All these same, all other routine methods that we use can be used in this case also. Okay, so these are all the points that you have to keep in mind for this question of paraplegic